Interprofessional house, which I think is great. Learning about vestibular rehabilitation or vertigo rehabilitation is not just for physiotherapists. It's an interprofessional team learning opportunity, because the more we learn about what our colleagues do when we or our patients have these issues, we know the professional that potentially can help them. We know where to send people. And I think that's so important. So I so really do appreciate the fact that we have inpatient people, outpatient people here. We've got physios, we've got pharmacists, we've got nursing, we've got people from all over the place. And I think that's absolutely wonderful. And Peter and I were talking about that earlier. So I'm very happy to have here Teloniatis here with us presenting. He's a graduate from Queen's University, has a Master's of Science in Physiotherapy. He became interested in vertigo after an internship observing a treatment maneuver being performed that had really instant improvements, and I can imagine that would be fairly moving. He completed a thesis proposal on the Self-Epley maneuver for post-traumatic BPPV, which stands for...
Well, I'll let the crowd find out.
Okay, good. Yeah. And then I did also postgraduate training in the same acronym that remains a mystery to me. So thank you very much, everybody, for coming, and I leave you in good hands here. I pass you over.
Thanks, Judy. So good afternoon, everybody. My name is Peter Teloniatis, and I'm from the Aurora Prime Physiotherapy and Sports Rehabilitation Center. I would like to start off by sharing with you a story of, as Judy mentioned, my first physiotherapy internship. First day comes along, and I'm starting my internship at a physiotherapy hospital in Kingston. And as I enter into the physiotherapy department, I notice a patient is being tipped off the edge of the bed. And my eyes kind of connected with that patient's eyes. And next thing I know, those eyes are twitching. And I'm like, what's going on? So I was startled, but at the same time I was intrigued. So I ended up asking the physiotherapist working on the patient a little bit more information, and that led me to doing as Judy mentioned, a thesis proposal at Queen's University for post-traumatic BPPV and the efficacy of the Self-Epley maneuver. And I'll be talking about that in the future near the end of my slides. But just with a show of hands here, I just want to get an idea of who we have here today. Actually, we got a great audience. How many of you are physiotherapists? Okay. Nurses. Awesome. Pharmacists. Fantastic. And any doctors in the house? Fantastic. And any other professions that I missed? OTs, fantastic. Thank you. How can I forget, right? How can I forget OTs? Yeah, so fantastic. Okay, great. So my second question to you all is, not sure what your level of background is with this topic, but how many of you know what actually BPPV stands for? You in the front here?
Well, I've suffered from it. So
okay.
So it's benign postal something vertigo.
You got it.
Other P.
That extra word, does anyone know what that is? Paroxysmal, exactly. So benign paroxysmal positional vertigo. So I would like to, what I would like to get across to you all today is, if you come across a patient who's suffering from these symptoms of vertigo, I would like for you to be able to determine whether that patient could benefit from any physiotherapy treatment, from a physiotherapist who's trained in vestibular rehabilitation. And I would like to give you guys an idea of what our typical assessment and treatment strategy would be to address these signs and symptoms of BPPV. So as you can see here on the outline, these are the topics that we're going to be discussing today. So a 2009 study determined that 35% of all people over the age of 40 will be experiencing a vestibular problem in their lifetime. Okay, that's huge. So, but BPPV is not considered a life-threatening condition. However, it can tremendously impact and disrupt a person's work and social life, as well as pose health hazards to them if they're increasing, by increasing the risk of falling, if there's any association with the dizziness and vertigo and imbalance. So Healthcare costs associated with the diagnosis of BPPV alone approach $2 billion. Now, this is an American stat, but I mean, you can approximately estimate around $200 million in Canada if we were to downsize it to maybe 10% of the population. $2,000 on alone is spent acquiring a diagnosis of the condition BPPV. And this is through various referrals, through MRI, CT scan, whatever is decided to be done. So obviously you can see there's a tremendous health expense and burden on our healthcare system here. So a lot of patients come in and describe to their family doctor, to their loved ones, that they're experiencing some form of dizziness. So I would like to make a distinction between what dizziness and vertigo are. So very simply, dizziness is a term used to describe a variety of sensations. So it could be lightheadedness, swaying, the feeling of disequilibrium, and the feeling of being disoriented, and also vertigo. Now, vertigo specifically is a type of dizziness that's defined as very simply the illusion of movement occurring in the environment. So your patient will often describe it as the room is spinning or I'm spinning. So it's very important to make this distinction with your patients to make sure that they're not used interchangeably. So benign paroxysmal positional vertigo, BPPV, what does it stand for? So benign, meaning it's not going to kill you. It's not a serious central nervous system disorder. Paroxysmal, meaning that it comes on rapidly and suddenly through a provocative position. And positional vertigo, essentially what we mentioned earlier, is the spinning sensation that's felt by the patient when they're put into these provocative positions and the hip positioning relative to gravity. So BPPV is a peripheral vestibular disorder of the inner ear, and it's characterized by, again, repeated episodes of positional vertigo. It was named by Dix-Hallpike in 1952, and BPPV is the most common form of dizziness in the elderly, and accounting for 26% of all dizziness. So, as you can see here, when a patient presents with vertigo, there are a number of conditions that could be the problem. There is BPPV, which is, as you can see here, represents 42% of cases, and it affects 64 out of every 100,000 people annually. It affects people primarily between their 5th and 7th decades of life, and there are essentially higher rates in women, and that's in particular with BPPV that's considered idiopathic, where there's no real direct relationship to anything else, it just happens on its own. However, with younger populations and with individuals who have actually suffered from a post-traumatic brain injury, the men-women balance is more even. So it's more of a 50-50 balance there. So as you can see here, there are a number of other conditions that produce vertigo. Vestibular neuritis, labyrinthitis, it represents 41%. Meniere's disease, 10% of cases. And as you go further, obviously the margins are much narrower, just 1% or under 5% essentially for the remainders. So what causes BPPV? Essentially what happens is you get fragments of these things called carbonate crystals, or autoconia, and they're abnormally present within the semicircular canals. So these things are kind of like, if you're to think of them just temporarily right now as hula hoops. You got 3 hula hoops in your vestibular system, okay? And when the head is placed in a provocative position, the patient will describe it as a brief episode of vertigo. And essentially, you get primary or idiopathic BPPV or secondary BPPV. So you can see the primary, most of the time we don't know where it comes from. It just happens to the patient, and that represents the majority of our crowd here, 50 to 70% of BPPV patients. But it can also come from head traumas, so in 7 to 17% of the population. Viral labyrinthitis, so if they have some form of virus or ear infection or whatnot. Meniere's disease, migraines, and also inner ear surgeries, just under 1%. So when patients are usually describing their symptoms, they'll usually begin with, so as the patient is tipped over, is tying their shoelaces or whatnot, they'll first describe it as, there's a brief latency period, nothing happens, and just for a couple seconds, and then this is followed by sudden severe attacks of either horizontal or vertical vertigo. And patients will actually describe the most common movements is rolling over in bed, laying down in bed from a sitting position, and then also sitting upright from a laying position. And you can kind of tell which side it's at, whether it's the left or the right, because the patient will say, every time I turn to my left, or every time I roll over to my left, that's when I get it, or every time I'm tying my shoes, that's when I get it. So you can kind of, and also, you'll notice they're like, I've been deviating, they'll mention that they'll deviate to the left when they're walking or whatnot. So subtle changes or subtle movements like that will kind of gear you more if it's the left inner ear or the right inner ear that's the issue. Now, vertigo is also associated with some of the symptoms, including lightheadedness, nausea, and the feeling of disequilibrium. And maybe 1 in 10 to 14 patients will also notice that they will be vomiting, actually. So these are some of the symptoms that are associated with vertigo. So from a clinician standpoint, what do you see? So when you tip over a patient, you would see nystagmus. Now, that refers to the repeated and rhythmic oscillations of the eyes. Now, you can, in BPPV, there's what's called jerk nystagmus, where you have like a fast phase of like the eye twitch and a slow phase. So usually you can determine which side of the inner ear, which inner ear is the problem, depending on the fast phase of the nystagmus, of the twitching. But the nystagmus can be horizontal, right, in this plane. Vertical can be in an oblique fashion, and it can be torsional as well. And I'll be showing you guys in a couple videos soon after these slides what I mean by what nystagmus really is, right? So a great table, actually, by Cohen and Jerbeck from 1999 showed a good list of, they took 85 patients and subjects, and they kind of asked them to kind of describe the symptoms, where they are getting their symptoms of vertigo. So as you can see here, the three most common is, like I said, rolling over in bed to one side, lying down in bed, and sitting up from a lying down position. And obviously you can see, so it's not that crystal clear. There are obviously other positions and movements that cause the vertigo, but these are the main three that we typically see in these patients. So what forms BPPV? So, sorry, what I meant by that is there are three different types of BPPV. We have a posterior semicircular canal, BPPV, horizontal semicircular canal, BPPV, and an anterior semicircular canal, BPPV. So these are the three hula hoops of your vestibular system. And as you can see here, the posterior semicircular canal with 85 to 95% is clearly the most common. Most of my patients who come in have that one. That's what they're most commonly see. That's what most of them are coming for. However, some will come for the horizontal semicircular canal, 10 to 14%, and the anterior semicircular canal BPPV is very rare. You only see it in 1%. There's usually something else underlying behind it, so you would want to delve into a little bit more. Sometimes it means some central nervous system issue or something else is going on. But so there are three different types of BPPV, and you can distinguish whether, and there are subtypes as well. So you can distinguish by whether the detached otoconia are free floating from within the affected canal, and this is called canalithysis. And there's also cupulolithysis, which is essentially when the crystals, these otoconia, are kind of attached to this attachment of the hula hoop called the cupula. And this is a little bit more stubborn to deal with. So we will show you guys in a bit how to approach each one of these.